So the medical chart will contain both patient information and copies of all the treatment orders prescribed. Of course, these are protected health information. Only people who have a need should be using these charts or in those charts. If the patient is not under the care of a nurse, it's a neighbor or something like that, the nurse shouldn't be going to check on things. Same with pharmacy. So I've mentioned what an addressograph is. So the standard patient identification information, it's either handwritten on the order or on a computer-generated ID label, or it can be pre-printed, and that's called an addressograph. So as I was just stating, access to the protected health information, things like the medication order in the chart, restricted, and information may be viewed only by the departments that must see the data. So that includes people like pharmacy, lab, nursing, physicians. It could even be physical therapy, respiratory. So there may be other departments that will be accessing that information. The treatment orders kept in the medical chart. Traditionally, it was a carbonless system, about 3-page to write through. So now most of it's done electronically, but it would be copies of medication, diagnostic, laboratory, dietary, and other orders. The original copy will stay in the chart, and carbon copies are either hand-delivered, faxed, scanned electronically, which is how they primarily are today, if they're not entered, or they could have been sent through a pneumatic tube. Maybe kept at the nursing station or maintained on a computer record. So today we are primarily computerized. The order is most often written by hand using a combination of medical terminology, signet instructions. Again, this has changed now because of the CPOE. So the physician goes in and generally it's a series of drop-down menu selections. So some things are just a little different. In the pharmacy, they receive the order. So if you have one main pharmacy, that's called a central pharmacy, and a lot of those orders are generally processed through the central pharmacy. There may also be a satellite pharmacy, so an OR pharmacy, like a little mini pharmacy outside of the main pharmacy in the hospital, or an ED pharmacy, an emergency department pharmacy, or an ICU mini pharmacy or satellite. So those might occur throughout the hospital. So orders can be entered there or retrieved through those areas. Now, specialized pharmacy software assists in identification of patient medication allergies, including cross-sensitivities, drug-drug or drug-food interactions, the appropriate medication dosage, duplication of therapy, contraindications. So just like when you were processing your community prescriptions and you got that drug utilization review screen or interaction screen pop up, the same thing in the hospital. So if you get those warning or interaction screens, we want to make sure that we clear that with a pharmacist. Now, more specifically about this chapter and what the purpose is how to read labels. So the compounded sterile product labeling, once the orders are put into the computer, a label will be generated. The labels will most often be affixed by the technician, but in certain cases the pharmacist may be doing that. Now, federal law requires that the pharmacy labels accurately identifying the ingredients and the amount of each ingredient in the final sterile compound. So there are specific guidelines, not only federally, but also by the state board. And we'll look at the state board guidelines towards the end of this presentation. On the CSP label, it has to have specific information. Information about the product, its administration and storage requirements, its expiration date or beyond use date, and who the preparer is. So here's a label. So the product has to have the name of the drug, so in this case it's gentamicin, and the amount of the oh, I'm sorry, I'm jumping ahead here. That's the additive. We're talking about the base. I'm reading words and not reading content. So specifies the name, concentration, and amount of the base. So in this case, let's see if I can get this pen to work this time. So dextrose, 5% water, 100 milliliters. So our concentration is the 5%, and the amount of the base that we're using is 100 milliliters. Now, oops, let me do a highlighter for this one. The additive. So the name of the additive is gentamicin, and then how much? 100 milligrams. So when we get this order, we could determine that there's 100 milligrams of drug and 100 milliliters of solution. Now, what this does not tell us is how many milliliters of our gentamicin give us that 100 milligram dose. So that's where your dosing comes in. We did some review on that last week with the assessment review, and chapter 5 we'll be doing more math. So those are important components of the label that must be on there. Now, also, if it's an IV push or an IV piggyback label, so if we go and look here, we have IV piggyback, which we also have piggyback here, and it's also noted. So that's the example, but on the actual order, it's going to say piggyback, IV, push. We also need to know, when is this medication going to be given? Now, this is not telling us Q 12 hours. So because it doesn't tell us that, we're going to assume that this is a one-time dose, but it's going to tell us that it's infused over 60 minutes. So we don't see the traditional flow rate of milliliters per hour generally with a piggyback. If the medication administration is not ordered by the physician and the package insert's unavailable, the pharmacist may find the information by looking at a reference, including Trissel's Handbook of Injectable Drugs, looking it up as a pharmacy reference source through Micromedics or RPH Global to find out what is our base solution. So if the doctor just wrote the order for gentamicin 100 milligrams IV piggyback, that's sufficient order. So we would either have to go, generally in the computer, those order sets are already entered. So we would have a speed code and we'd look for gentamicin 100 milligrams and it would tell us what solution it was in and what the proper mix is. And we'd select that and the label would print. If that was not available, then we would have to go to one of these references and find what base solution we should use. In contrast to administration time, an infusion rate is used on a large volume parenteral. So the other one just told us to infuse it over 1 hour, but because we're administering 1,000 milliliters or a liter bag, we need to know how many milliliters per hour this will be. So an infusion rate, now you see also on here that this is giving us that it's a large volume parenteral. Oops, didn't mean to do that. Let's see if we can take that off and go back with our highlighter. All right, so our large volume parenteral, and it just may say IV for that. Now the other thing that we can see on here is our storage. Keep refrigerated, warm to room temperature, and then once it's made, we also have all of our patient identifying information, their billing number, the prescription number. So on a label, just like in a community pharmacy, when we generate a label in the pharmacy or generate a medication order, it's assigned a specific identification prescription number, patient's name, and their location in the hospital. So this patient's in ICU, room 8. Now, once this order is completed, Generally, the expiration date is going to be 24 hours from the time that it's prepared. But again, we might need to check our references because some things are going to be only stable for maybe 6 hours. So we'd put the date and time, 24 hours probably after it was made, and then the technician would initial, and then the pharmacist would verify, and then they would initial. Also, for push, things can be sent to the floor as a syringe. So we want to send ceftriaxone 250 milligrams in 2.5 milliliters of solution to be given IM. And that would be a one-time injection in a syringe. Now, when we process syringes and send those to the floor, we need to remove the needle and put a syringe cap on it. And then we will generally cover that with a tamper-proof seal. Other things that might be noted with your label are auxiliary labels, and that helps clarify any special instructions. So if the order is stat, we want that to be brought to the nurse's attention, so we put a stat sticker on it. Oftentimes we compound irrigation solutions in the pharmacy, but they look like a regular IV. So in that case, we would want to make sure that we use the auxiliary label that lets them know it's for irrigation only. Some hospitals have protocols to note when there's potassium added into an IV bag because that could have some serious implications. If it shouldn't be kept in the refrigerator, because a lot of times they'll see piggybacks and they'll toss them in the fridge. Certain things should not be refrigerated, like mannitol comes out of solution. Now here we have some drug labels. So when we talk about the risk factors associated with sterile compounding, one of the levels is immediate use. So if someone prepares an IV at bedside, but they're not the person who's going to hang the IV. So if we're on a code and the doctor wants a Versed drip, so the technician who's there or the pharmacist that's there makes the IV right there on the card, hands it to the nurse to hang. It must have a label on it. So we have some labels that can just be filled in with pen in the emergency of the protection of that compounded sterile product. So those are what labels might look like. Another requirement of a compounded sterile product label is the expiration date, which we often refer to as a beyond use date. So if we look at this label here, this looks a lot like your most pharmacies. I don't know why it doesn't want to highlight label. So we've got the patient's name, we've got what time the medication is supposed to hang at midnight on 6/15, the base solution, 250 milliliters of D5W, the medication that's added, vancomycin 1 gram. In this case, it does give us the rate, 250 milliliters per hour. It may say infuse over 1 hour. But here, highlighted in yellow, is the beyond use date. So when does it expire? Also, there should be a place for the pharmacy technician as well as the pharmacist to sign. Here's our prescription number. So expires at 2400 on 6/16. All right. Several factors determine the expiration dates. Some of them include stability of the drug in its compounded form. We know often as it's sitting on the shelf, it's stable. Once we mix it in something else, it will change those chemical properties. It can affect the expiration date. It could extend it or it could shorten it. Storage requirements. Is it refrigerated? Must it be kept out of the refrigerator? Those should also be on the label. Every CSP label should identify the pharmacy person who compounded it, generally the technician, and then who verified it, generally the pharmacist.